Welcome, everybody. Welcome to PEM Rules, the Pediatric Emergency Medicine Podcast, Episode 4. And today we're going to discuss some PEM rules still in the category of clinical care tips, specifically that have to do with intensive care and shock. So, you guys probably know, despite being an emergency physician, it is actually quite uncommon for me to actually encounter true emergencies. As we mentioned in previous episodes, most of what I do is really not urgent or emergent. I do a lot of reassurance to parents. I don't find myself actually intervening most of the time. However, every once in a while, I obviously do encounter true emergencies, cardiac arrest, surgical emergencies, severe asthma exacerbations, etc. I intubate patients every once in a while. It's not every day, but I think it's very important for us to keep our skills and know how to manage serious acute emergent conditions. So the following rules really have to do with shock and other serious emergencies that every once in a while I encounter. Rule number 12. The management of shock is a chess match against death. Think 2 or 3 steps ahead. By definition, shock and all other true emergencies are time sensitive. Under many circumstances, providing some medication sooner rather than later can really save a life or make a clinical difference. It is therefore very important to think ahead and communicate that. An example is when I order a fluid bolus in a patient with shock, I always communicate to the nurse, let's have another bolus ready to be given after this one in case we need it. Another example is when I resuscitate a baby in cardiac arrest, most commonly a SIDS baby, and I do give epi, I always communicate to the nurse, let's draw another dose of epi to be ready but not given yet. So I think it's very important to be a step ahead, kind of predict what may or may not happen, worst case scenario, and be prepared for that case. Rule number 13, although sounds really funny, maybe, really is true. The only way normal saline can kill a child is if he drowns in a pool full of it. This is something that I tell the residents all the time when I see them spending more than 2 minutes in front of the computer trying to figure out what is the fluid bolus for a patient. Yes, it's 20 cc per kilo, but guess what happens if you give 25 cc per kilo? Well, nothing. The only way normal saline can kill a child is if he drowns in a pool full of it. This is also one big important difference between the adult side and us. I think in the adult side, giving too much fluid is always a very legitimate concern. We have a lot of patients on the adult side with cardiomyopathy or low cardiac output secondary to several MIs and whatnot, and those patients often get pulmonary edema when they get fluid overloaded. But in the pediatric side, not really a problem. I give fluids like there's no tomorrow. I often joke with the residents, and it really is kind of true, with the same thing about albuterol. The only way albuterol can kill a child is if he drowns in a pool full of it. And let's be honest, it's the same for Zofran. Although I am aware of 1 or 2 case studies where pediatric patients with prolonged QT had arrhythmias secondary to Zofran, it is still pretty rare. And if Zofran can keep the child out of the hospital and make my PO challenge more successful, so be it. So remember that the only way normal saline can kill a child is if he drowns in a pool full of it. Just give the kid some normal saline. Rule number 14. Do not ignore unexplained tachycardia. I'm always a little weary when I see a child who's tachycardic, but I'm significantly more weary when the tachycardia is unexplained. A child who is afebrile, not running around, not crying, should not be tachycardic. That always makes me a little nervous and I think hard about it. What is going on? If the child has fever and very tachycardic, I can live with that. I can give him some Tylenol, hope for the fever to subside and go down, and usually it does. And then if the tachycardia resolves or improves, I send the child home assuming the exam is normal, child is vaccinated, etc. The child with normal temperature really has no business to be tachycardic, and if he is not, I think, is he dehydrated and I need to give him fluids? Is he septic and I'm just not seeing the fever because mom has been treating him with Tylenol around the clock? But I pause for a second and I think hard about it before I dismiss the tachycardia. So unexplained tachycardia should really make you a little nervous and pause for a second and think, are you missing something? I think it's very important to make sure that tachycardia can be explained. Is the child dehydrated and needs fluids? Is the child septic and I'm just not seeing the fever because mom has been giving Tylenol on the clock? For example, if I see 2 patients, let's say 4 years of age, who are healthy and vaccinated, One of them is 104 with a tachycardia of 160. The other one is afebrile with the same heart rate. I'm actually a lot more worried about the patient who's afebrile. Why is he so tachycardic if he has no fever, assuming he's sitting on mom's lap and looking fine? That to me is very, very concerning. The child with the high fever and tachycardia probably is going to get some Tylenol, and if I see that tachycardia resolved, if the patient is healthy, vaccinated, and has a non-focal exam, I'm probably going to send him home. But the child who's afebrile, not crying, not running around, and is so tachycardic, that makes me a little bit more worried. So do not ignore unexplained tachycardia. Rule number 15. A bolus over an hour is an oxymoron. Although I gotta admit, I do that sometimes, but I find myself giving a bolus over an hour for patients with sickle cell pain crisis, where the fluids is actually part of the treatment, but they're stable. But I think it's very important to remember, if you're giving fluids to a child who's actually hypotensive or in compensated shock, giving it over an hour really is an oxymoron. A child who has hypotension or compensated shock needs the fluids as soon as possible, and the only way to do that is via the push-pull method. So a bolus over an hour is really an oxymoron. Rule number 16. You can leave an oral airway in until the child spits it out. If they don't gag it, they need it. So maintaining an airway is obviously one of the most important jobs I do. It's the A in the ABC. If I think a child is obtunded, unresponsive, I place an oral airway. If the child gags it out, great. That means that the gag reflex is there and he's protecting his airway. That's fantastic. But if the child is not gagging it, I keep it in until he does, or until I get the patient intubated. I think it's important to remember that any patient that is not gagging the oral airway has an unprotected airway, and it's our job to protect it. Either keep the oral airway and ventilate the patient, or intubate them as soon as possible. Rule number 17. Manage a resuscitation 3 important tasks at a time. Most of us adults really cannot focus on 2 or 3 things at any given time, especially under stress. That is why, especially during resuscitation, it is very important to break things down and break it down to 2 or 3 important tasks at a time. So saying something like, okay, team, the glucose is within normal limits. The next 3 things we're going to do are get an IV, give a fluid bolus, and then go to head CT to make sure there's no bleed. I break it down, keep it easy, and keep it simple. This way, it is easier for the team to comprehend what I need to have done and how to go about it. Overwhelming the team and myself with a long list of tasks is just going to make things more chaotic and is unlikely to be successful. So manage resuscitation 3 important tasks at a time. That is all for today, guys. Some pediatric emergency medicine rules that have to do with shock and intensive care. Remember, rule number 12, the management of shock is a chess match against death. Think 2 and 3 moves ahead. Rule number 13, the only way normal saline can kill a child is if he drowns in a pool full of it. Give the kid some normal saline. Rule number 14, don't ignore unexplained tachycardia. Either resolve it or explain it. Rule number 15, a bolus over an hour is an oxymoron. And rule number 16, you can leave an oral airway in until the child spits it out. If they don't gag it out, they need it. Rule number 17, remember us adults always have a hard time focusing, so manage your resuscitation 3 important tasks at a time. Break it down, keep it easy, and keep it simple. That is all for today, guys. Thank you very much for listening. See you next time.